rotablation in complex cases, techniques and troubleshooting. Now, when I got this topic from Srinivas, I was, for a moment I had to think out of so many cases of rota that we keep on doing, what is complex, what is simple, and where do I start and where do I end. So finally, and since the time is very short, that was the most important factor. Since it is only 15-16 minutes that I would be talking about. So I picked up some cases where possibly you may have to put in some little extra tip. You may require extra tip or a trick to get into the right place and get an optimum result. So with those objectives and a few clarities in my mind, I picked up some cases which I would go quickly. Some of these slides are old. They may give me some problem. Most of these patients are without IVOS because I have, wherever even IVOS has been done, I have deleted for the sake of time. Now, conventionally, when you do rota ablation, this is the kind of case that you do. The patient is selected on the basis of his angiographic appearance. You can see here that this patient has got a highly calcified stenotic lesion which is not too long. That is one of the important criteria. Undilatable with balloon, relatively straight segment at the target site, and IVOS shows, if you have the IVOS, it shows superficial calcification as has been shown in the IVOS pictures below. Now, it is also very well now established that the patients who have a severely calcified coronary artery disease and undergo PCI, there's an increased risk of major adverse cardiovascular events when the stent is underexpanded. And the commonest cause of underexpansion of the stent is a moderate to severe calcification. And if the stent is underexpanded, it can lead to stent thrombosis and, as you all know, high risk of instant restenosis and target vessel failure. So there are several techniques which have been evolved over the past 4 decades to treat patients with highly calcified coronary artery disease. But I would say emphatically that the largest experience and possibly one of the most user-friendly, now I'm saying user-friendly because I have a very large experience, but it needs some learning curve. But at the same time, a lot of experience is available on a technique called rotational atherectomy. Of course, we have now got 2 additional devices for calcium. One is orbital atherectomy and the second is intravascular lithotripsy. But they have a niche in selected patients. Now, this is an old case, that is why not working. So, anyhow, this was a simple case to show you that it is a simple LED which was treated with rota ablation, and this was final result. But then the problem is that all disease coronary arteries are not the same. They are not all simple cases of calcified coronary artery disease, and they are highly complex, tortuous, and with variable degree of calcium. For example, here is a diffusely diseased, highly calcified vessel, both LAD and circumflex. Then we have an extremely tortuous, highly calcified, and severely diffuse disease, which also involves the left vein distal portion, which is also highly calcified. So such patients may also require rota ablation if they deny surgery or if they are not suitable for surgery. Then we have a highly calcified moderate stenosis with a sharp double bend. You can see that there is a 90-degree double bend here, and it is a highly calcified. It is not very easy to get a rota down in this kind of a vessel. Then this is a heavily calcified large size right coronary artery with a critical stenosis in the proximal segment and with a TIMI-1 flow. So such cases again would require a lot of skills to do. Another case, which is CTO, calcified CTO for the past 10 years. We were able to put a wire with a lot of difficulty, but then the question is nothing goes in, nothing goes in. So finally, with some tricks, we manipulated a rota wire down and then finally did a rota. Now, this is a patient who's very unique. One of the worst cases I've done, a underexpanded in-stent restenosis. Underexpanded stent in the L6, which was done about 2 years ago. And patient came with angina and had a calcific in-stent restenosis. You can see in the proximal part of the circumflex. Here are another patient with acute MI, heavily calcified diffuse disease, infarct-related artery, LAD. You can see here all the vessels are badly diseased. This patient came in the middle of the night with a blood pressure of 85-90, hypotensive, LVF, and this was his coronary anatomy. And we did a rota of the LAD during the primary angioplasty. So let me show you now. First problem is when you have inability to advance the rota floppy guide wire through the entire length of the lesion. Now this does happen in some of the cases, for example, like this. You may take a lot of time in guiding a rota wire, which is a very difficult stainless steel wire to manipulate. It often gets bent. So in such cases, don't waste time. You use a microcatheter with a conventional wire and then advance the microcatheter and change it to the rota wire. And then you do a step burr technique. That's a very important. In such a long, diffusely diseased coronary artery, step burr technique is the key, because otherwise you would have a lot of slow flow. Patient may go into hypotension. And this is the final result after putting in 6 stents, including the left main, and the patient did very well after that. In fact, he came with acute LVF with the ejection fraction of 30% and has done well for 2.5 years. He had a CA larynx and then died. Now, this is a patient, as I said to you just now, where we had a very tight stenosis in the right coronary artery. Now, even the wire does not advance. So, we picked up initially a Judkins guiding catheter to be make it simple, but the wire wouldn't cross. Wire crossed the region, but it won't advance. So, what I thought was that I will take the burr into the proximal part, which is the non-disease segment, and then go to a slow speed or dynaglide mode and remove the friction between the burr and the wire and then advance the wire. I hope, but that also did not work. So then I changed it to Emplas guiding catheter. And Emplas guiding catheter, and same thing, I took the wire and kept it in the proximal part of the ICA, and now I took a 1.25 burr, put it on the dynaglide mode, and then advance the wire. Now it went. So the purpose was to remove the friction between the burr and the wire, and then allow the burr. Then once the wire was deep in, then we put it into a full speed and advance the rota 1.25 followed by 1.5, and then rest was done by balloon and stent, and you can see the final result. Now this is a patient who had a critical stenosis in the proximal RCA with a Shepherd Cook. This is a case which I did live in one of the conferences. It may, I hope it works. This is a problem. No, if it doesn't work here. This was a Shepherd Crook RCA with a 99% very highly calcified RCA. And again, we had to choose a Emplas guiding catheter. And with the help of an Emplas guiding catheter, we could manipulate the wire in the same technique as in the previous patient. And finally, we were able to get rid of the calcium. Finally, we put 3 stents, one the proximal part, one the mid, and the patient also had a significant stenosis in the distal part of the RCA, including PD, which was also subjected to rotablation, and finally the final result. Now, this is a patient where, again, we had inability to advance the shortest burr through a diffuse and heavily calcified RCA, where we use a half rota technique. Now, you see this kind of vessel. Many people who even do rota would dare to, would be very, very scared of doing this kind of a patient. But patient had very symptomatic and other disease was only in OM, so he was not willing for a bypass surgery, nor was I very keen to send him for a bypass surgery. So we took a first Judkins catheter, but that did not help. Then we took a Emplas guiding catheter, and now the burr doesn't go through the proximal part. It just entered into the proximal part but would not go. So Everything came out. We changed to a employer's guiding catheter, which would come little later. But by this time, we thought, let's try a balloon now, because we have entered into the proximal part of the stenotic segment. So we took a 1 millimeter balloon and dilated a little bit, whatever we could do. And then we took a employer's guiding catheter, changed the entire assembly, and then did a put a rota wire, and now the 1.25 millimeter burr went through the lesion, and we ablated this vessel through and through. So this is called half rota ablation. So after having done that, this patient took almost 7 hours of procedure in 2 stages. First procedure was 3.5 hours with 700 ml of dye. Second stage we had to cut short because patient got tired, too much of dye was used, so we gave him a 4 days of rest inside the hospital. And then in the stage 2, we deployed stent. And because we had to use IVL in this patient, then we had to use cutting balloon. So many things were used in this patient. So this was the final result. And the patient has been doing very well for the 1.5 years. Now, this is a sharp angle with which I showed you just now in my previous slide. Again, I don't know. Yeah. So here what we did was that there was a double bend in the vessel. So what we did was we changed the rota wire to a extra support wire. Now sometimes the extra support wire tends to decrease the angulation, or makes the bends a little smoother, and it allows the rota burr small size and then bigger size. So this is what we had to do, and they are not working here anyhow. Now this is the case which I was saying, Srinivas, we had some problem last time also. Now they were working outside just now. This was a very interesting case which I showed you in my initial part of the talk. This lady had a stent deployed in Mysore, and 1.5 years she kept on getting angina soon after the deployment of stent, because the stent never got expanded fully, because at that time also patient had possibly a fibrocalcific stenotic lesion. But the operator there didn't do any IVUS and just put in the stent, which did not expand. So she came to me, and of course we were also not able to do IVUS, but we could see the stent is under expanded. Now we passed a wire, balloon would not crack the stenosis, as you can, I think previous slide showed that the balloon did not crack the stenosis. Sorry. It's going forward or backward? Hmm? This was the one. Yeah. See, you see the balloon, waste in the balloon, failed balloon dilatation. So what we next did was, wanted to pass a rota. Now even the rota doesn't go. So we were unable to pass even the 1.25 meter burr because of two reasons. One is the stent was not expanded. Of course, balloon had done some job in expanding the stent. But the second problem was the bend beyond the stent. So the balloon would, the rota burr would not cross the bend. So what we did was, uh, at that time, the problem was the rota burr got stuck. So we had another problem. There was entrapment of the burr. So with the conventional administration of nitroglycerin, some gentle traction on the burr, repeated attempts, and then successful disengagement was obtained. Now we took another swipe at it, and you can see the difference between these two. Now in your left hand side, you can see the rota wire tip is lying in the anterior branch, and the burr would still not cross. So what we did was, let's change the position of the wire tip into the posterior branch, and that may change the wire bias. And somehow the trick worked. Now you see the burr has crossed into your right hand side. You see, as soon as the wire was put into the posterior branch, the rotabar cross. And then, of course, things became easy, and this is the final result. Last two cases, this is acute STEMI, which I showed you. This patient had totally occluded LAD, but all the vessels are diseased, highly calcified. So we did a thrombosuction, and after thrombosuction, we found that it's a highly calcified vessel with TIMI 1 flow. Patient was still hypotensive. So we did a rotablation, just 1.25 millimeter per. And this was the final result. Now, lastly, this is again a very interesting case, which was possibly has only one or two cases have been reported in the world literature. This patient came to us with a post-CABG 5 years down the line. Uh, he had Lima, which was functioning, one OM graft, which was totally blocked, and this was the second OM graft, which showed a picture like this. We cannulated this graft, and we thought it's a very simple task. We took almost half an hour and exchanged 5 wires, but this lesion would not get crossed. Finally, we were able to get one very floppy wire, I don't remember which one. But the question is, the balloon would not go. We tried guide Zilla, etc. I'm just going to finish. But finally, we decided that since even the balloon is not going, let's put a rota wire. So it was not difficult because rota wire, how do we put the rota wire? But we were lucky on a day. So finally, the rota wire went through. Now, these are some of the wires which are being exchanged. Finally, the rota wire went. This is the conventional wire, the balloon doesn't go. And now the rota wire went through it. And then we thought for about 15 minutes whether we should do a rota in a graft or not. I took courage to do a rota 1.25 and then followed by 1.5 and then put two stents, and this was the final result. Now, slow flow, you all know it very well. This is a pre-PCI angiogram. I think we can skip this. It happens most often when you have got a very large tortuous vessel and you don't use a step bud technique. If you use a step bud technique, then slow flow is very uncommon. Now, lastly, burr entrapment resulting in perforation of the right coronary artery was first reported by me way back in 1999. And this was, till then, no case has been reported. Of course, now there are about 15 odd cases have been reported. So this is my experience of rota till June 24, 1732 cases. We had perforation only in 2 cases, burn entrapment in 7, out of which serious entrapment took place only in 1 case, which I reported where the perforation took place, but patient was saved. Major slow flow in 2, need for emergency surgery in 1, and deaths occurred in 2 patients. So therefore, in conclusion, rota in complex cases of coronary calcification requires experience, skills, and ability to manage complications. In experienced hands, it's possible to ablate calcification in most patients, thereby increasing the horizon of PCI.